of a 75-year-old lady presenting with complaints of decreased vision in the left eye since the last 6 months. On examination, her vision in the right eye was 612 N6 and that of the left eye was 3/60 and N36. Both eyes had early nuclear sclerosis of grade 2. Fundus examination revealed a large macular hole in the left eye. OCT confirmed the size of the hole to be 1050 microns. Now coming to the surgery. After performing the cataract surgery, vitrectomy was initiated after making 325 gauge ports. With the help of triamcinolone acetonide, the vitreous was stained and posterior vitreous detachment induced. Vitrectomy was then completed up to the periphery. Fluid gas exchange was done. And BBG was used to stain the internal limiting membrane. Following this, an ILM flap is created using the finesse loop in the inferotemporal quadrant and extended superotemporal. The flap was also extended to the part inferonasal to the macula. Peeling was proceeded with concentrically and the peeled ILM gradually folded inversely towards the edges of the macular hole. Fluid gas exchange was repeated. A soft silicone-tipped cannula was used to gather the flaps to cover the macular hole, and the surgery ended with C3F8 gas injection. Postoperative OCT confirmed a type 2 closure of the macular hole and vision improved to 624 N8 in the same eye, thus showing that it is worthwhile to attempt macular hole surgery even in cases of very large holes. Coming to the second case, a 55-year-old lady presented with complaints of decreased vision in the left eye for the last 6 months. Her vision was found to be 5/60 and N36 in the left eye and 612 N6 in the other eye. Both the eyes had cataractous changes of nuclear sclerosis grade 2. She mentioned history of having a macular hole surgery in the left eye 4 months back. Fundus examination revealed a full thickness macular hole, which was again confirmed by the OCT. The patient had undergone a previous vitrectomy. After performing the cataract surgery, the attempt to stain the remaining ILM was done after performing fluid gas exchange directly. A free ILM flap was created temporal to the macula. The same was used to plug the macular hole with the help of the closed ends of the forceps. As the first free flap turned out to be quite a small one, another slightly larger flap was fashioned from an area further temporally, and that flap was again used to plug the macular hole in a similar way. Fluid gas exchange was then repeated and the eye filled with C3F8 gas before port closure. Postoperative OCT confirmed closure of the macular hole and the vision recorded was 612 N8, giving a satisfactory result. Coming to the third and last case. This case shows that if a flap is lost during surgery, it can be grasped again. A 77-year-old lady presented with complaints of decreased vision in her right eye for the last 7 months. Her vision was counting fingers at 1 meter in right eye and 6/9 N6 in the other eye. She was pseudophakic in both eyes. Fundus evaluation revealed a large macular hole in her right eye, which was confirmed by OCT. She was taken up for surgery and after making 325 gauge ports, vitrectomy was started anteriorly. IVTA was used to stain the vitreous and PVD was induced. After completing the vitrectomy, fluid gas exchange was performed and the brilliant blue dye used to stain the ILM. A negatively stained ERM was noted centrally along with the positively stained ILM. Using a finesse loop, an ILM flap was created peripheral to the ERM in the part inferior to the macula. Same was done superiorly. With the help of an ILM forceps, the flap was grasped and peeled gradually towards the edge of the macular hole centripetally. As the cutter was being used to try and trim the flap, the whole of the existing flap got inadvertently cut, leaving nothing to cover the hole with. At this stage, fluid gas exchange was repeated and restaining was done with the hope to check for any remaining ILM, some of which was luckily found just temporal to the macula. The peel was then extended nasally towards the disc. When an attempt was made to peel the existing ILM flap from the temporal area, the flap created again got torn inadvertently. Now, as the peeling was being completed, a large free floating flap was noted near the posterior pole which was swirling around, and that opportunity was grasped to tuck that free flap into the hole with the closed end of the ILM peeling forceps. An area of inadvertent touch to the retina which was noted is lasered. Fluid gas exchange was performed again and thankfully the flap stayed in place. The case was closed after injecting C3F gas. 1 month postoperatively, the patient had gained vision of 624 and N12 in the right eye. The OCT revealed a successfully closed hole. Thus, this video shows how different difficulties may be faced while doing macular hole surgeries and how they can be managed with different means to deliver a successful result to the patient. Thank you.